Bismillahirrahmanirrahim. Hadith of the day. One who pleases his parents has wearily pleased Allah, and one who has angered his parents has wearily angered Allah. Assalamu alaikum everyone. I am Dr. Marina Akhtar, PGR Community Medicine. Today I am critically appraising the research article under the kind supervision of my respected professor, Dr. Saira Afzal. Article of the for the critical appraiser is action. A title of the article is Action Plan to Enhance Self-Management and Early Detection of Exudations in COPD Patient, a Multi-Center RCT. For the critical appraiser of this article, I am going to use Consort checklist. Here is given the Consort checklist. Title and the abstract. According to Consort checklist, the title and abstract should show identification as randomized trial in the title and structure summary of the trial design, methods, results, and conclusions. As the title is Action Plan to Enhance Self-Management and Early Detection of Extubation in COPD Patient, a Multi-Center RCT, here is identification as a randomized controlled trial. In the title, yes, it is mentioned. In the abstract, in the background, early detection of extubation by COPD patient initiating prompt intervention has shown to be clinically relevant. Until now, research failed to identify the effectiveness of written individualized action plan (AP) to achieve this. And the methods and designs, the current multi-center single-blind RCT with follow-up period of 6 months evaluate the hypothesis that individualized APs reduce extubation recovery time. Patients are included from regular respiratory nurse clinics and allocated to either usual care or the AP action plan intervention. The AP provides individualized treatment prescription, pharmaceutical and non-pharmaceutical related to color-coded system status reinforcement at 1 and 4 months. Although usually not possible in self-management trials, we ensured blinding of the patient using a modified informed consent procedure in which patient give consent to postpone information. Exhibation in the both study arms are defined using uh, Anthonson symptom diary card algorithm. The clinical COPD questionnaire CCQ is assessed every 3 days. CCQ recovery time of an extubation is the primary study outcome. Additionally, healthcare utilization, anxiety, depression, treatment delay, self-efficacy are assessed at the baseline and 6 months. We aimed at including 245 COPD patients with 7 hospitals and 5 general practices to capture a prior sample size at least 73 exubations per study arm. And next discussion. In the discussion, this RCT identifies if an AP action plan is an effective component of self-management in the patient with COPD and clearly differentiate from existing study in its design, outcome measures, and generalizability of the result, considering that study is carried out in the multiple sites, including general practices. In the abstract or summary, in structure summary trial design, yes, it is mentioned, methods are well explained, result, no separate heading of the result, and conclusion are given under the heading of discussion. No separate conclusions are mentioned. Now, this is the Consort checklist points for introduction. In the introduction, background is chronic obstructive pulmonary disease is characterized by flow limitation that is not fully reversible. This airflow limitation is usually progressive and associated with abnormal response to noxious particles or gases. COPD is the major cause of morbidity and mortality throughout the world. Depending on the etiology and severity, these periods may be referred as exubation. Exubations are important because their impact on morbidity and mortality. They may hasten the disease progression by accelerating the decline in the lung function and have significant effect on the quality of life. Adjusted for the disease severity, patients with exubation show higher mortality rates than the patient without exubation. Until now, little data is available in which methods are effective in enhancing the self management associated with the exubation. A potential effective method to help the patient to recognize and anticipate on early symptoms of an exubation is an action plan AP. APs encourage patient to identify daily variation in symptoms and when needed take the appropriate action, that is change medication regime or visit healthcare provider. Until recently, now next is now, in the aim and objective, the present study aim at evaluating the effectiveness of an AP as an addition to care as usual in a randomized controlled trial. We hypothesize that in event of an exubation, an AP aiming at the early contacting healthcare provider and thus prompt intervention lead to the faster recovery in symptom and health status in the patient with COPD. Secondary outcomes will include self-management behavior such as contact or treatment delay, self-efficacy, healthcare utilization. This article provides a detailed description of the study background, targeted population, study methodology, subsequently compares this with previous randomized trial regarding effectiveness of action plans in the COPD treatment. Main objective is to evaluate effectiveness of individualized action plan on health status recovery time in the event of an exubation. Secondary objective is to evaluate effectiveness of individualized action plan on in the event of an exubation on and symptom recovery time, treatment delay, healthcare utilization, health related quality of life, depression, anxiety, and self efficacy. In the introduction, according to Consort checklist, scientific background is given, explanation, there is a well explanation of the rationale and specific objective and hypothesis is also mentioned. This is Consort checklist list for methods. Method are this study is conducted as a single blind randomized controlled trial with a 6-month follow-up. Patients are randomly assigned on either care as usual or treatment with an individualized action plan as an addition to care as usual. The randomization procedure is performed by a respiratory nurse RN. To conceal the assignment sequence, a central web-based service on a 1:1 basis is used. Randomization is stratified by center and gender. Study population, the patients are selected based on the following inclusion criteria. One, that is post bronchodilator FEV1 over FVC ratio less than 70%. And second point is age should be greater than 40 years. Third is smoking history for more than 20 years or 15 pack years. Four is diagnosis of COPD as a major functionally limiting disease. And fifth is current use of bronchodilator therapy. Exclusion criteria are first is primary diagnosis of asthma. Onset should be less than onset if less than 35 years or greater than 12% post bronchodilator reversibility. Second is primary diagnosis of the cardiac disease. And third is the presence of disease that could either affect mortality or the participation in the study. This picture showing the this is schematic overview of the study procedure. Patients are recruited and informed 2 weeks before randomization. Reinforcement of the AP used by telephone only for intervention group. Interventions to optimize the AP action plan for disease related patient utilization. to guarantee that AP does not conflict with the evidence-based guidelines on COPD care, 5 experts in the field of COPD self-management and COPD guidelines were consulted using semi-structured interviews. With the resulting version of action plan, a pilot study was conducted from December 2007 until May 2008. In this study, 121 response rate, 71% COPD patient, age 61.4 plus minus 10.5 years, FE1 47.7 plus minus 18.5%, received an AP were followed up to 42 days. 13 patients were lost to follow up. 11% patients reported both format and content of this AP are highly satisfactory. In this pilot study, we acquired experience and understanding in the patient recruitment, patient response, study procedure in the self-management research, daily diary symptom assessment, analysis, and patient perception of action plan use. And the primary outcomes that are mentioned in details with their identification tool. These primary outcomes were health status, recovery time, and secondary outcomes are symptom recovery time, health related quality of life, anxiety and depression, self efficacy, and favorable health status, healthcare utilization, and cost effectiveness. Tool for their diagnosis is also mentioned in the article, and these all outcomes are mentioned in detail. Now coming to the sample size, hence we adapted the general rule for computing the sample size required for our t-test. It in a normal distribution, the distance between the first quartile and the medium is approximately 0.65, 7 times the standard deviation of the distribution. Thus, we assume that distribution of the recovery time median 12 and interquartile range is 8 to 16 to be normal. The mean of this distribution will be 12 with standard deviation 6. Sample size is calculated based on the smallest detectable change of 1 day CCQ uh, clinical COPD questionnaire unit using the aforementioned 15% rule would mean a sample size of 63 two-tailed t-test. 1.15 plus minus 15% equals 73 exubations are needed in both arms to have 80% in chance of detecting a difference using two-side alpha 0.05. And then biases are also mentioned in the articles. Selection bias by attention or dropout, or resentful, demoralization, and compensatory, rivalry, and desire to please the investigator or loyalty bias. These biases are mentioned and they try to assess these biases. And in the data analysis, SPSS 15 for Windows will be used for the data analysis. Difference in the clinical COPD questionnaire symptom recovery time between both groups will be evaluated using Whitney U test. Number of exubation will be reported as a weighted exubation rate. Statistical significance of the weighted rate ratio are calculated using Poisson regression model, including on over depression parameter to account for variability in the exacerbation rate between the patient. Other variable will be analyzed using pair student t-test for continuous data, chi-square test for binomial data, and Mann-Whitney U-test for ordinal data to determine the magnitude of the treatment effect. Consa effect size are calculated for continuous variable measuring difference in pre and the post change. Blinding and ethical consideration. For obvious reasons, blinding in the behavioral and self-management intervention is not usually possible. However, a modified informed consent procedure enable a single blind design. In the present study, an informed consent to the postponed information procedure is used, keeping the patient unaware of the action plan being the major study aim. In the method section description, according to Consort checklist, description of the trial design, yes, it is mentioned. Important changes to methods after trial commencement, yes. Eligibility criteria for the participant is mentioned. Setting and location where the data were collected, yes, this is mentioned. The intervention for each group is mentioned, defined. Pre-specified primary and secondary outcomes were measured. Any change for trial outcome after the trial commenced, no, this is not mentioned. How sample size was determined, this is also mentioned. In randomization method used to generate the random allocation sequence, thus it is mentioned. Type of randomization is also mentioned, but not in much detail. Mechanism used to implement the random allocation sequence, that is mentioned. Who generated the random allocation sequence and who enrolled the participant, who assigned the participant to the intervention, that these were respiratory nurses. If relevant, description of the similarity of intervention, and statistical method used to compare the group for primary and secondary outcome, these are not clearly mentioned. Methods for the additional analysis such as subgroup analysis and adjusted analysis, these are also not clearly mentioned. And these are points of the consort checklist for the results section. As the results are not separately mentioned in the article, but it is given with discussion. Now the result and discussion section. In the result and discussion section, the current study aimed at the intervention of the hypothesis that a written AP enhances early detection and the prompt action and is consequently beneficial and exubation outcomes recovery time. A priori methodological decisions in the current study are compared with the strength and the weakness for the past randomized trial. The study characteristics that are shown in table 1, I will show you in the next slide, show that the current study has some innovative feature and differentiate from the other three studies evaluating isolated effect of an action plan as an addition to care as a usual. Within the current study, the intentional multi-central design targeting at the inclusion from both general practices as well as outpatient clinics was chosen. This optimized not only the external validity of the study, allowing better generalization of the result, but also enable the capture both patients and the mild airway obstruction and the most vulnerable patient high exubation rate. And this table showing the characteristic of the studies evaluating isolated effects of an AP as in addition to care as a usual. And these are the current study showing current study intervention and other comparing with other three studies. In this study, recruitment, OC and GP, outpatient clinics and general practice are chosen, while in other studies only general practice is chosen. In this study, pilot study is also done, while in other two study, pilot study is not done. In the intervention, early contact is present in the current study, and outcomes are exubation recovery time, but in other study it is St. George respiratory questionnaire, and randomization is individual, and blinding is patient versus investigator, and the stratification is done by the center, and the follow-up is done in the 16-month, powered on exubation recovery rate equals 1, and sample size calculation is 245, while in other studies it is less, there is small sample size. Finally, the current study clearly differs from the other studies in the primary outcome in which study is powered, aiming at evaluating effectiveness of a single component intervention necessitates being reserved on powering on the general outcome measures such as hospital admission. Therefore, the current study aimed at specific and accurate assessment of the effectiveness of the AP on the patient-centered outcome in the presence of exubation, since this is what the action plan is developed for. In addition, a clinical relevant advantage of the assessing exubation recovery time is that it assesses effectiveness in all exubation episodes, not only those followed by the healthcare contact or the hospital admission. Effectiveness is termed of decrease CCQ recovery time is equivalent to a decrease in impact of these episodes on the health status, thus highly clinical relevant from a patient perspective. Detecting an effect on the recovery time of exubation, the primary outcome, is an essential first step before trying to prove that intervention can increase health related quality of life or reduce hospital admission. And in conclusion, this randomized control trial identifies whether an action plan is an effective component of self management in the patient with COPD and clearly differentiate from existing studies in its design, outcome measures, and robustness. As the results are not mentioned in the article separately, so most of these points are also not mentioned. For each group, the number of participants who are randomly assigned received intended treatment and were analyzed for the primary outcome. This is not mentioned. For each group losses and exclusion after the randomization together with reason, this is also not mentioned. Date defining the period of recruitment and follow-up, that is mentioned. Why the trial ended and was stopped, this is also not mentioned. A table showing baseline demographic and clinical characteristics of each group, this is also not mentioned. For each group, number of participant denominator including each analysis and other analysis was original assigned group not mentioned. For each primary and secondary outcome, result of each group and the estimated effect size and its precision, such a 95% confidence interval, this is also not mentioned. Result of any other analysis performed, including subgroup analysis, adjusted analysis, distinguishing pre-specified from exploratory, that is also not mentioned. All important harms or re-intending effect of each group, this is also not mentioned. But in the discussion, trial limitation addressing source of potential bias, imprecision, and if relevant multiplicity of the analysis, this is mentioned. Generalizability is mentioned to some extent, and interpretation consistent with result, balancing benefits and harms, and considering other relevant evidence, this is also mentioned to some extent. And in other, according to consort checklist, other information, registration should be given, protocol and funding should be mentioned. And this is other information. Competing interest is mentioned, that author declared that they have no competing interest, and author contribution is also mentioned, and acknowledgement is mentioned, and there is also ethical approval is also mentioned in this study. Registration number is mentioned, but name of trial registry is not mentioned. Registration number is mentioned in the abstract. Where the full trial protocol can be assessed if available, no, that is not available. And the source of funding and other support such as supply of drugs, role of funder, no, this is also not mentioned. Strength of this study. Title is self-explanatory and mentioned study design. Abstract is structured, bias was assessed, methodology was well explained, primary and secondary outcomes are mentioned in the detail, randomization methodology was explained, strength of the study were mentioned. But the limitations of the study are results are not mentioned in the abstract, no separate result were mentioned in the article, only one table is given under the discussion section to compare the current study with the other studies. Limitation of the study were not mentioned. There is no graphical representation of the result. No further research recommendation were mentioned. And this is a YouTube link of our channel where the all our presentations are uploaded. Thank you so much for your patience listening.